Hi, everyone. Welcome to Vitals Academia with New York Medical College's Bing Gap chapter. I am Angelique, co-president of NYMC's Bing Gap chapter, building the next generation of academic physicians, which is a national organization that aims to help underrepresented groups become more aware of academic medicine as a career option and provide them the resources to further explore and potentially embark on an academic medicine career. Vitals Academia is a new podcast that aims to highlight the careers of academic medicine physicians and demystify the process for how they built their careers. Today, I have with me Dr. Richard Rohr, who is a graduate from New York Medical College with an additional master's degree in healthcare management from Tulane University. He has a diverse medical career, which includes starting one of the first hospitalist programs in Connecticut, and also includes experience in primary care, specialty care, long-term care, rural health care, public health, and hospital management. He also serves as a clinical assistant professor at New York Medical College and is working on creating an area of concentration in this institution as well. So thank you so much, Dr. Rohr, for being one of our speakers, and we're really excited to have you.
Well, thank you for inviting me.
Yes. So I guess just to start off, can you tell me a little bit about your journey of becoming a physician and what led you to pursue medicine in the first place?
I was always fascinated by the human body. And so I was thinking about medicine from an early age. Um, I am a little bit of a nerd and probably under different circumstances, I might have become an electrical engineer. But um, I was in college during the 70s and engineering was not doing very well in that regard as in terms of job opportunities. I graduated from Columbia in 1976, and basically if you were a good talker, you went to law school. If you were good in science, you went to medical school. So I went to medical school.
Okay, awesome. Yeah, it's so funny. I feel like people kind of go back to like whatever their that science interest usually is what brings people into medicine. So really awesome. And then I guess like how would you say your early years of your medical career were like, and what made you to decide? Because I know you had like a career more in like as a hospitalist. So what made you eventually transition into academic medicine?
Well, I've had basically a rather diverse career. I started out training as an internist and pulmonologist. But again, based on my experience, again, again, the late 70s, New York Medical College really did not have a university hospital. So a career in academic medicine was fairly unlikely. I think very few students from my class actually pursued that route. A few did, but not very many. We were basically going into private practice. I never wanted to go into an individual practice. Again, as a result of my experiences in New York Med, we were farmed out all over the place. I got to see how medicine was practiced in a lot of different settings. And I got very interested in the organizational aspects of medicine. Um, there were things developing called health maintenance organizations, which basically don't exist anymore, but they were very popular in the 1980s. And so for my first practice experiences after completing training, I worked for two staff model HMOs in Massachusetts and Connecticut. And it gave me experience working with a multi-specialty group. Um, the good parts of it was that we really had a lot of close interaction between the members of the group. We could talk about things and try to organize care for patients a little better, a little bit less fragmented than was typically the case for physicians in private practice. The downside of it was that it was a very bureaucratic, they were basically rather bureaucratic organizations. They were having trouble financially. They initially did very well, but again, costs started to run up on them. They really didn't have a good way of controlling it. And actually, both of the two HMOs that I worked for have subsequently went out of business. So that put me on a different path. Because of my experiences, because of my knowledge as a pulmonologist, I was recruited to a small chain of long-term care facilities that was specializing in medically complex patients, which included patients with long-term mechanical ventilation, which is why I was brought in, They also dealt with a lot of patients with brain injury, which is also actually a fairly interesting area to deal with. We were trying to develop an alternative um, setting to standard nursing homes for patients who needed somewhat medically complex care, but really didn't need to stay in the hospital necessarily for a long period of time. So we were trying to create something sort of in between hospital and nursing home. Unfortunately, the financial arrangements didn't really pan out, and I had to leave that job after a couple of years. And then I answered an ad in the New England Journal of Medicine that was placed by a small hospital near my home, and they were looking for a daytime house physician. And that's the title they used because the word hospitalist had not yet been coined. Uh, I went and talked to them, and it looked interesting. It was a small hospital that had been authorized for 150 beds, but because of competition from other hospitals in the area, they were running an average daily census of about 30 patients. So they needed some help, and it seemed like an interesting situation. So I went in there, uh, and it turned out to be really a transformative experience for me because I really had a chance to get my finger into almost every pie within that operation. I was on every committee. Um, I was basically supervising the intensive care unit. I was running the CME program. I was running the peer review program, and so it got me interested in trying to go further in medical management. So I entered a program sponsored by what was then called the American College of Physician Executives. It's now called the American Association for Physician Leadership. And I went through their certification program and enjoyed it and wanted to go further. So I enrolled in a program they had developed with Tulane University, which led to a degree called Master of Medical Management. And I went through that program, received a degree, and finishing that, I was sort of unclear where I wanted to go for the next couple of years because most of I was wanting to stay in the hospital environment, but most of the jobs, again, there was something called vice president for medical affairs, which was basically a matter of making nice to the surgeons to get them to bring more cases to the hospital. Didn't really attract, but again, people started talking about quality, which is medical quality, which is an area I've been very interested in, and sort of changing that role of VPMA to a chief medical officer with significant responsibilities for quality improvement. So I put my toe into the water and started answering ads and worked with various recruiters. Um, but again, the problem is coming from a very small hospital. It's kind of hard to move up into anything bigger. Finally got a job with a small hospital in upstate New York as, again, taking a job as vice president for medical affairs, which initially looked like a good situation, but uh, the problem being that it was in a rural area. It lacked specialists, particularly surgeons. I spent a lot of time trying to recruit doctors to the hospital, not very successfully. Uh, there was a hospitalist program that had been started by an outside vendor, which quickly defaulted on their contract. And I spent a very unhappy year trying to get out of that contract and start a new hospitalist program, a new vendor, and then various other stresses and strains. So I had to leave that job after a year. Uh, a friend of mine from the Tulane program was a chief of medicine at Guthrie Clinic in northern Pennsylvania. He asked me to come over there and kind of straighten out their hospitalist program, which had gotten off to a slow start, and did that for a couple of years, but there really wasn't a good way to go from there. So I was looking at um, where to go from that point, and actually took a job with a company here in Pennsylvania that had just been acquired by Optum, which is part of United Health Group. And they were helping hospitals with medical necessity evaluations because there had been a very strong Medicare started denying need for inpatient care in substantial numbers, and hospitals need help with that. So I took that job. Turned out to be very interesting. It it introduced me to the importance of medical documentation because it's all about what you write down. It's not what you keep in your head. It's really about what you record. Why? What did you do? Why did you do it? Can you explain that um, to a medical director or other concerned party? So I did that for 10 years. The job kind of ran out of gas. They were kind enough to keep me on to my 10-year anniversary, which allowed me to keep certain benefits. But but basically the job was eliminated. So at that point, I looked around at what I would do. I had lots of money because I made $1 million on stock options for United Health Group, and I had saved pretty well through the years. So money was not a concern, but the question is what to concentrate on. And I had had some discussions with the alumni folks at New York Medical College, and they persuaded me that maybe this was a good time to make a larger donation to support their clinical skills laboratory, which I did. Um, but as sort of as part of that, I had a discussion with the dean of the college at that time, who was Dr. Nadler then, and talked about my interest in trying to promote medical communication. And he hooked me up with a group that was doing an intercession program on health system science. And so I became one of the faculty members in that program. We've now done that for 4 years, both in person and virtual. And sort of growing out of that, having further discussions with the new dean, Dr. Schluger, and with the associate dean, Dr. Ludmer, um, I had thought about giving some money to support work in that area. And they steered me towards, well, what would you think about trying to develop a concentration in health system studies? And so that's what I've been working on for the past several months. We are so basically building on that health systems science week that we do for the M2 class, and then trying to create something that would continue as an area of concentration uh, into particularly into the fourth year, right now we are working with Westchester Medical Center on developing an experience for the students to work with their leadership, both physician and non-physician. We're still working that out, so it's still coming. But I think once we have that nailed down in the next couple of months, we'll be able to start that. And I think that's going to be a useful thing for our students because the world really has changed since the time that I graduated. New York Medical College was oriented toward producing people for clinical practice. Uh, we are moving more. I think one of the nice changes since Turo became involved with the school is to build up the research capabilities, particularly student research, and try to engender more interest in academic medicine. But one of the problems we have in doing the Health Systems Sciences Week is that Um, I'm really one of the few people on the college who has a faculty appointment in the School of Medicine who actually knows something about health system science. Right now, we are dependent upon, we have Adam Block from the School of Public Health, who is a health economist and teaches on that subject. And we have Joan Foley from the Touro Law Center out on Long Island, who comes in and helps us talk about health law. But um, we've tried to do small group sessions with the students and found it very difficult to find preceptors to help with that because most of the faculty doesn't feel comfortable teaching this stuff because they don't know it. They've never had any experience with it. So I think this is really the issue, and particularly since this is a podcast about frontiers in academic medicine, I think that where we'd like to go with this concentration is try to get students interested in researching health systems, understanding how physicians function within these organizations and how they can function better, because there really is a paucity of information on that. And so that's really my hope, is that we can lay the groundwork for something that eventually becomes a department within the college. Now, there's a lot that has to happen uh, before that can occur, because I mean, there at this time, to my knowledge, there is no medical college that has a department of health system science. There are some schools that have developed small groups within other departments to look at that, but um, there's not a lot of research activity. There's not a lot of grants available, which is why there isn't a lot of research activity. So those are really the obstacles that we have to overcome in order to make this happen. But ultimately, I think it has to happen, because you have to have particularly as value-based healthcare becomes more and more prominent. Uh, the faculty is, this clinical faculty is going to have to learn how to do this, and they're going to have to teach it to the students.
Yeah, that's definitely true. I could definitely see like it's very true that we don't have a lot of faculty that does experience in that. And I think it's really exciting that, you're working on trying to create a department in the college in that. So that'll be really exciting to kind of see that come to light. I guess kind of just like piggybacking off of that, even though it is like introduced in the M2 class, I think a lot of people don't understand the importance of having a health science background. So I guess can you just kind of explain a bit more about that? Like, why is it important for not
Yeah,
only students to know it, but also, what kind of leadership opportunities could or needed to have that kind of background?
yeah.
Can you
I mean,
explain?
the real when you explore the literature of medicine, and particularly physicians' organizations, you hear a lot about autonomy. And physicians have lost their autonomy. Uh, in a private practice setting, you can do pretty much anything you want. Um, Even practicing within a hospital, physicians were given very broad discretion as to, and so I'm probably, I have to say, probably too much discretion in terms of their personal behavior, which has created a lot of organizational problems. And one hears a lot about disruptive physicians and how to deal with that. Because frankly, for many years, doctors were just, particularly surgeons, were told, bring your patients in, you can behave any way you want. And that just doesn't work. Um, so we're trying to deal now that we're losing autonomy. The fact that it's really significant, because right about the time that I started having these discussions with Dr. Nadler, the American Medical Association had reported that for the first time, that since they started keeping statistics, less than half of all physicians in this country were self-employed. So the majority of those are working for hospitals, but we've seen a lot of activity from private equity groups acquiring practices. In fact, the company that I worked for, Optum, I was in the analytics division, but they have a division called Optum Care, which has over $100,000 doctors affiliated with it. It's actually the largest medical group in the country. And basically 1 out of 10 doctors in this country is affiliated with Optum. So the fact is that we are now working in organizational settings, and there's really a problem. I mean, I've studied business, and the paradox is that physicians are frontline production workers. They actually make the healthcare. But in order to do that, they have to exercise judgment on a level that is generally reserved for executives. So, how do we resolve this paradox between being a frontline production worker, which is usually an area where the worker has very little control, with having to function more like an executive? And the business literature doesn't have any answers for us. So that's an area that really needs to be explored and developed to understand how physicians function this way. Now, I live in the Philadelphia area, and we have a chapter of the organization called the Society of Hospital Medicine. And a month ago, we had someone come up from Delaware, Wilmington, Delaware, where there is a large health system called Christianacare. And the physicians in that group have recently voted to join a union, which is very significant because up to now, union activity has been limited pretty much to interns and residents. So the New York City municipal hospitals have been unionized for a long time. There are other places where there are resident unions, but unions for practicing, attending physicians. This is something very new, and I think it's fraught with concerns. Unions are basically geared to the lowest common denominator. They are designed to protect the interests of the least capable and least motivated members. And if you are someone who prides yourself on excellence, you're going to be disappointed because in a union setting, everybody gets the same thing, no matter how good you are or how bad you are. And if that's all you want, that's fine. But if you want to be recognized for your talents, it's not going to happen in a union shop. So I
Mm,
think that's one of the big problems that we have to try to figure out is how do we deal with that issue that there are very significant issues um, of physician autonomy and how the working conditions, like how many patients a day are you going to see and what kind of support staff you're going to have, what kind of facilities you're given. Uh, Years ago, the doctors just created that for themselves. You set up an office and you equipped it, to the best of your ability. And particularly back in the 70s, doctors could basically borrow almost any amount of money, so it wasn't really that big of a problem. Um, but now you're going to be going into a situation where a health system is going to put you in a practice setting. They're going to give you staff. They're going to give this the amount of staff they want to give you. They're going to give you the equipment that they want to give you. They're going to dictate um, how you acquire patients and how many patients you want to see each day. And that is becoming a source of stress for many physicians. So we have to figure out how do we deal with that? How do we manage these organizations in a manner that really keeps uh, physicians professional, able to maintain reasonable autonomy? And we need researchers to study this. That's
mm,
really where I think that's really the challenge for academic medicine, and I think slowly we will get there. I can recall that years ago, organizations like the American College of Physicians uh, strictly dealt with scientific issues. But now, when you look at their publications, they've got a lot of stuff about medical practice. And they're
mm.
not the only ones. American College of Chest Physicians, of course, AMA has been sourced, but a lot of specialty societies that were once strictly concerned with scientific issues are now getting into the issues of practice management and finances. So I think it's just a matter of time before the medical schools move in this direction because the students need to be equipped for this.
Yeah. So would you then say that it's more important for students to become equipped in this in order for them to be able to practice successfully now that a lot
Yes.
of organizations are combining, or do you think it's more so just so that they're ready for the next step if they want a position in leadership later down the line?
Well,
Or
I think it's both. I mean, clearly we need to have folks who are going to move forward and move into leadership positions. So I think that's one of the things I want to try to accomplish with this area of concentration is to give students exposure to both physician managers and non-physician managers and see how they interact with each other. because I think that's very important to understand. So clearly some people, but even for those who want to focus on clinical practice, they've got to figure out how to survive in this environment. Now, I give a lecture to the M2 students, and in fact, I've just, after this last iteration we did in September, I've really thought about it and kind of revamped it, because the point is that in order, you're going to be judged as a physician basically by a set of codes. You know, basically everything you do as a physician is reduced to a set of codes, and that gets analyzed and sorted in different ways. And one of the important issues is that you're going to be judged by the outcome statistics of your patients, and that's based on the severity of illness that's reported. If you use vague language that makes it hard to say just how sick your patient is, dyspnea does not have the same meaning as acute respiratory failure. Altered mental status does not have the same meaning as encephalopathy. And unfortunately, a lot of doctors use wishy-washy language in their medical records, and it's very hard to assign an appropriate level of severity and risk of mortality to their patients. And these folks are going to find out that they get judged very harshly, that they are not regarded as good doctors, because they don't say exactly what they did, why they did it, and how it turned out. And that is, I think, one of the key messages that we need to bring to our students. If you're going to survive in a health system, the medical record is really the face that you present to the health system, because most of the people running those things are never going to see your real face. And that's the point. In private practice was all about making relationships with individual patients. And those are still important. But the fact of the matter is the patients have a lot less choice now about who they're going to see as their doctor, because there are very strong financial incentives to you basically have to sign up with a health system in most insurance plans. So um, it's really the people who run the health system that are the people that you have to uh, impress, and you have to do that through your documentation, because you're just never going to meet most of those people.
Mm. Yeah. Yeah, and that's like a really good point. I didn't really think about the fact that, with private practice, like the patients, like the one you're interacting with, but when you have a big company that's kind of, your employer, like the games kind of change, and now you're kind of being evaluated on a different level than you would have been if you had your own practice, or even if you were in
Mhm.
like a smaller facility. So it's like definitely a different way of thinking about it. And I guess like that's why, as a baseline level, like knowing how to document things in the proper way with like that health science information like background will help you to kind of set yourself for success, like no matter
Yeah,
what you end up doing. So yeah,
yeah,
interesting. Yeah. I guess like what would you tell a student who is interested in this but doesn't know kind of where to start or what path to
yeah.
kind of take?
It's difficult right now, which is why I'm trying to create this area of concentration to give people. We actually already have. There's a Dr. Thomas Busso, who is another alumnus of New York Med, actually a year before me, and still working as a hospitalist and clinical hospitalist in Arizona, who does a business of medicine course, which is a more didactic kind of presentation. I'm hoping that we can kind of pull that into our concentration and give students exposure to Dr. Busso's material before we turn them out and actually go into the hospital system to see how this stuff works. Um, but I think the key thing is that, unfortunately, right now, if you're serious about understanding how the health system works, you got to go outside for additional training. Uh, there are organizations, again, the Society of Hospital Medicine has a leadership academy, which is quite good. I actually was involved in some of the initial discussions on that about 20 years ago. Um, and there are degree programs like the one that I attended at Tulane, which are uh, designed to give you a background. But I think, and this is, it doesn't make it doesn't make sense to tell every student, no, you need to have a business degree. That doesn't make sense. I think for those who really aspire to become leaders in the health industry, yes, you're going to have to get that additional education. You're going to need that additional credential, but you don't need to do, in fact, I would tell you really not to do that right away because you're not going to be able to use it immediately because in any system, any organization, you have to establish your credibility as a clinician first. So you're going to have to impress the people that you work with that you're a really good doctor, that you are able to treat patients well, that you're able to heal their illnesses and work effectively in the traditional mode of physician. So once you've established your credentials as a clinician, then you can start moving into, getting onto committees, taking on various assignments uh, within the organization, and sort of develop your talents that way. And then, if you feel that this is a direction that you really want to go in, then you would need to enter a master's program to get additional training in healthcare management.
Okay. All right. Yeah, that definitely makes sense. I think like having a solid foundation clinically will also like make you like more credible, and also like that's the primary thing that we kind of went into. You can't be probably like a good healthcare manager unless you have like a solid clinical foundation
Yeah.
and know how to like work on the ground floor, so to say, for
As a sidelight, there has been a movement for many years to try to create a board certification in medical management. And this was something that actually kind of created a significant schism within the American College of Physician Executives because half of the leadership wanted to push people into master's degree programs, and the other half really wanted a board certification. And they came close to getting it, working with the American Board of Preventive Medicine, but the American Board of Medical Specialties said no initially because it didn't really fit their paradigm. It again, this was a sort of a non-clinical kind of distinction that doesn't really fit with other things that they certify people in. Plus, there was no specific residency training program. Now, what has happened is that there are now some fellowships in medical management and several boards, including preventive medicine, emergency medicine, and I think family medicine, are now offering an exam and certification in medical management, and the American Board of Medical Specialties has gone along with that. So that is now another pathway for those who may not. But however, those I've seen the descriptions of those fellowships, and they look a lot like a master's program. So I'm not sure that there's much of a difference there. In fact, some of them actually do award a master's degree.
Oh, okay. I didn't realize that there were fellowships like that. I didn't even
Yeah.
actually realize there was like fellowships for health management. So that's like really good to know.
Yeah, so that is developing. So there is something, it's needed, and we just have to figure out how to get this more securely planted in the medical schools because we really need faculty who understand this stuff.
Yeah, definitely. Yeah. Awesome. So I guess then, I guess I guess pivoting a little bit back for like your career, is there anything that you felt like was really impactful either in medical school or as a resident that kind of helped you to kind of build yourself in this way and kind of build your career the way that it's taken?
Well, the answer really is no, because this is not something that anybody in medical school or residencies were talking about. That there was really no, and I mean, you could become a chief resident in a residency program, but basically that was sort of a sort of a nod toward academic medicine, and it didn't really prepare you for a leadership role as such. It was just taking care of stuff that the head of the department really didn't want to be bothered with. So unfortunately, no, I really had to do this all on my own, and that I think made it more difficult, possibly more interesting, but again, there really was not a way to develop mentorship uh, or guidance in this area because it's just not an area that anybody was interested in.
Mm, okay. Yeah, I guess like I mentioned, like, it wasn't a big thing, so that makes a lot of sense. So I guess then would you say for students who are interested in this, like, kind of making sure they're preparing themselves clinically, but then and keeping in the back of the mind, doing a master's or a fellowship, but is there anything else that they should be doing, or do you think it's just kind of make sure that you're kind of preparing yourself clinically as much as you can, and then once
I
the
think that's
opportunity
really, yeah, I
in
think
for leadership
clearly your
roles down the
focus,
line? Yeah.
your focus as a as a new medical school graduate needs to be on getting through a clinical residency, developing your clinical skills, um, and then getting into the healthcare system, finding your first job, getting into an organization, and kind of feeling your way through it. And hopefully, we can develop tools that will make that process easier. But right now, you're pretty much on your own.
Okay. It's definitely good to know and kind of keep in mind.
Yeah.
And then I guess if there was any advice you would want to give like a medical student or maybe a resident, what advice would you give them?
I think I think it's important to look around and think about, you know, again, I mentioned earlier, one of the interesting things about New York Med, and still, I mean, although we do have a university hospital now at Westchester Medical Center, and Metropolitan has functioned a little bit like a university hospital, though it's not quite the same thing. Uh, we still have a lot of clinical affiliations. They're sending students to Florida, sending students to Arizona, uh, up upstate New York, and I would suggest maybe trying some of that stuff to kind of see some of the different ways, some of the different environments in which medicine is practiced. Uh, so that, I mean, in a university hospital, there's certainly a group think that pushes you a certain direction, and when you have an opportunity to interact with people who don't think that way, you get some other perspective. So I think it's definitely worthwhile to at least try some of those opportunities to go. Not always fun to be going out to some place away from the mothership, but I would at least be open to that and try some of those opportunities to just get a feel for some of the different ways that medicine is being practiced around the country.
Awesome. Definitely good advice and good idea. I definitely did some of my clinical rotations in other places outside of just the city. Like I did some in Poughkeepsie and in Kingston.
Hmm.
So I got a taste like, community
Yeah.
hospital versus city versus
Yes.
suburban. And it is very different. So I think going into different states and like different parts of the world is definitely
Mhm.
great experience. So awesome. And then I guess just our last two questions. One, I guess what do you hope to leave as your legacy? Both in like academic medicine or health management science, or just like in general, what kind of legacy are you
Well, I
hoping?
think that basically what I'm hoping to do is to focus attention within academic medicine on the importance of health. I'm sort of loath to use the term health system science because, well, that is the title of a book that was published by the American Medical Association. And why is the AMA publishing a medical textbook? Because the academic community is not interested in this stuff. So they chose the term health system science. The problem is that there's not a heck of a lot of science. And I think that's really the key, that we've really got to start, we've really got to create some investigation. It's fine to get some people in to give lectures, but realistically, I think we've got to create an environment where uh, you have full-time faculty members who are actually looking into these questions and making it part of their work. Now there has to be grant support for that, and that's what's got to be figured out, what's got to be developed. But so do you put what comes first, the chicken or the egg? No, I don't know the answer to that, but that's really what I see as the contribution that I can make to medicine, to academic medicine, and try to promote this thinking and try to get it established as a ongoing part of the medical curriculum.
Yeah, that would be awesome. And yeah, I guess that you never think that academic medicine is really, or just academia is like what really pushes different ideas and initiative forward. So if academic medicine isn't taking this on, it's, could easily fall by the wayside or just not seen in the
Well,
importance of
I don't
of
want to say that
busy.
there's no interest, and I will tell you that in my discussions with Dr. Schluger and Dr. Ludmer, they're both interested in doing this.
Mm,
The problem is figuring out how do we push this forward? Where do we get the money to do it?
mm,
Um, and those are very difficult questions right now. So I think we've got to try, and that's really my hope with this concentration, that we kind of start to grow. Because you can't, I mean, even if $20 million dropped from the sky to create a department, the problem is, how would you spend that money? Where would you go to hire the people? I have no idea. So we
mm,
wouldn't really be able to spend that money so we really gotta have to, I think we're gonna have to grow those people internally,
mm.
and then try to get, and then hopefully other schools will pick this up so that you can really develop a community of scholars and try to create a movement. But yeah, it's still very, very early.
Yeah, yeah. Well, I guess exciting things in the works, and hopefully this podcast could get people interested in it. And if there's any M1s and twos who kind of want to get more involved in building
Mhm.
this, it seems like it's a great opportunity during your time at NYMC to kind of like leave your mark in this way and get involved
Yeah.
in something that's like really gonna be important with how you practice and like
Mhm.
be a big part of like how medicine is practiced in the future. So awesome.
Yes.
And I guess just to end it off, do you have any like parting words or anything you wanted to share before we end this podcast?
Well, I just want to thank you for inviting me to talk about this, because it's an opportunity to kind of get the message out. And I don't know what the audience is for this podcast, but hopefully it will find its way to, and that's the interesting thing about podcasts, because they exist on the internet, and you never know where they're going to wind up. And somebody tells somebody, and somebody refers it to somebody else, and maybe it strikes a nerve somewhere. So that's my hope.
Yeah, awesome. Yeah, hopefully the right person will hear this and it will kind of ignite a fire that they dig a little bit deeper and figure out like a new path that they didn't even know about before. So awesome. Thank you so much. Well, it was really great having you. We really appreciate you being on this podcast. This is another episode of Vitals Academia. Thank you all for joining, and make sure you subscribe to this page and see other episodes that are coming out. Thank you.